Um, Thank you very much to the organizers of this program for inviting me. I also want to acknowledge my contributing authors who are listed below. I have no disclosures and I have no financial support from any companies. I do have to disclose that I am a anesthesiologist and not a surgeon. According to the American Cancer Society, they estimated that in 2020 in the United States there will be almost 280,000 new cases of breast cancer diagnosed and about 42,000 deaths from breast cancer in the United States. Gartner and his group in their study showed that 47% of women treated for breast cancer experienced pain, and 58% of the women experienced sensory disturbances in the surgical region up to 3 years after surgery. Gartner and his associates also reported that half of the women that reported pain were reporting moderate to severe pain, in agreement with the estimates in the literature varying for pain between 25 and 60% of all women post-mastectomy, as well as 20 to 80% of them having sensory disturbances. D. Oliveira reported that chronic pain has been shown to affect up to 60% of patients undergoing surgery for breast cancer in his study also. An early study by Perkins in 2000 looking at chronic pain as an outcome of all types of surgeries found that particularly for breast surgery that there was 11 to 57% of the women had chronic pain at 1 year post-op. Excuse me. And studying the predictive factors for chronic pain in the Perkins study, they showed that preoperative factors included pain of moderate to severe lasting at least 1 month, as well as moderate to severe pain in the acute phase postoperatively. Psychological vulnerability was found both preoperatively and postoperatively as factors affecting the development for chronic pain. The role played by anesthetic management for mastectomy has been poorly studied and remains controversial. The questions such as can anesthetic management decrease intraoperative nociception? Can it decrease the immediate postoperative pain? Can our techniques decrease utilization of postoperative opioids, decrease postoperative nausea and vomiting? Can we decrease the development of chronic pain and decrease the long-term use and dependence on opioids? Azad noted that acute postoperative pain following surgery for breast cancer is known to be associated with the development of chronic pain and lower quality of life. In their study, the authors sought to analyze the relationship between differing breast cancer excisional procedures, such as reconstruction, etc., on the development of short-term pain outcome, that is, in the first 30 days post-discharge. Their conclusions were that younger age, preoperative opioid use, and longer length of stay were associated with higher levels of postoperative pain up to 30 days post-op. And they came up with a way of evaluating patients for the development of chronic pain in breast cancer patients. and it was called IDEAL, IDEAL. Identify the problems and specific risk factors, define a plan of perioperative management involving anesthesiologists, surgeons, nurses, and family members. But anesthesia management is not reported in this particular study. Explore the possible strategies such as use of multimodal analgesia and regional techniques when applicable. Act on these strategies, aggressively treat pain and prevent withdrawal from opioids, and look back and reevaluate the analgesic effect of your treatments, the functional status of the patient, and adverse events. In our study, we did a retrospective analysis, single center study, which aimed to analyze the short-term and long-term follow-up in patients who had total mastectomy between July 2016 and February 2018. All surgeries were performed by a single surgeon under general anesthesia with a preoperative paravertebral nerve block placement and preoperative oral medications such as gabapentin and acetaminophen. In addition, the general anesthetic was maintained with either a 50-50 blend of sevoflurane and intravenous propofol or just sevoflurane alone. And these patients received intravenous ketamine, magnesium, and ketorolac in the operating room. Patients having partial mastectomy were excluded from our study. 19 patients having immediate reconstruction after total mastectomy were also excluded. And another 4 patients were excluded because of incomplete medical records, leaving 124 patients for our total analysis. With respect to the methods that we used, the paravertebral nerve block was introduced to the patients in the breast surgery clinic as well as in the anesthesia pre-op clinic, so they were already aware of this procedure. Prior to the nerve block placement, the patients were given 1,000 milligrams of acetaminophen and 600 milligrams of gabapentin. The nerve blocks were performed in the preoperative area under mild sedation with 1 to 2 milligrams of intravenous midazolam, and then using ultrasound needle guidance in the prone position. The local anesthetic used for the paravertebral block was ropivacaine, 0.5% in 15 to 20 mLs as a single injection. The patient's satisfaction with the nerve block procedure itself was evaluated by a survey at the time of discharge from the hospital and reached 95.7% satisfaction with the nerve block. And that included the surgical care as well. Just to give you an idea of what it looks like under ultrasound, you can see in this image the transverse process. This is the pleura. This is our needle trajectory going just at the angle inferior to the transverse process at approximately the T5, T6 level. And once we penetrate the internal intercostal membrane, we will be in the paravertebral space. And once you start injecting your local anesthetic, you see the pleura being pushed down, the ligament or membrane pushed up, and the local anesthetic spread in the paravertebral space. And this is another image of it. This is before injection, and this is after injection. You can see the pleura and this internal intercostal ligament being separated. And we found that with a single injection, as published by Teague, the spread in the paravertebral space is multi-level and covers the entire chest area, as if we had performed a multi-level intercostal block. After placement of the nerve block, the patients were transported to the operating room where general anesthesia was induced and endotracheal intubation was performed. Propofol was used for induction and rocuronium for muscle relaxation. Intraoperative anesthetic variables, as mentioned earlier, were recorded, and they included the induction agents and agents for maintenance of anesthesia, as well as the opioids that were used during the procedure. The administration of ketorolac is 15 milligrams. Total ketamine dose was 20 to 50 milligrams. 2 grams of magnesium, 10 milligrams of dexamethasone, and ondansetron 4 milligrams for postoperative nausea and vomiting control. The estimated blood loss was also recorded, but no patients required a blood transfusion. The patients with severe immediate postoperative pain are in this column. The patients with mild postoperative pain are in the second column. And as far as preoperative demographics, comorbidities, we found none of the comorbidities associated with the amount of immediate postoperative pain that reached statistical significance. The only preoperative factors were preoperative alcohol use reached statistical significance in that the group that had severe postoperative pain or more severe postoperative pain had a higher incidence of preoperative alcohol use. The other factor was preoperative opioid use. That also demonstrated a statistically significant effect on immediate postoperative pain. The types of cancer, the staging, and preoperative cancer treatments did not reach statistical significance in terms of determining patients with immediate, severe, or mild postoperative pain. The incidence of immediate postoperative opioid use between the patients that had mild versus severe postoperative pain was significant, as indicated in this table, as well as the amount of opioid use in morphine milligram equivalents in the first 24 hours. Postoperative nausea and vomiting did not reach statistical significance between the two groups, but would be clinically significant since pain is associated with postoperative nausea and vomiting, and the group with the more severe postoperative immediate pain had more incidence of nausea and vomiting. The anesthetic maintenance between sevoflurane in 73% of the patients versus the combination of sevoflurane and propofol did not have a significant bearing on which group had severe versus mild postoperative immediate pain. Twice as many patients with severe immediate postoperative pain had significant pain at 1 week compared to patients with the mild immediate postoperative pain. And this association was carried out at 1 month as well, 62% versus 31%. And at 6 months, it was 29% versus 10%. And then finally at 1 year, 20.8% of the patients that initially had severe pain still had chronic pain versus only 8% in the group that had mild postoperative pain. Combining the two groups together, chronic pain developed in a total of 13.3% of our patient population. Other things such as infection or brachial plexus impairment did not reach clinical significance. Huvagimian and his group in a randomized controlled trial investigating the effect of general anesthesia as an independent prognostic factor for breast cancer recurrence after surgery found that there was no difference between the inhalational anesthetic sevoflurane and the intravenous anesthetic propofol with respect to circulating tumor cell counts over time. Likewise, et al. In a retrospective study found no association between the type of anesthesia, inhalation versus intravenous, on the long-term prognosis of breast cancer patient surgery. Unfortunately, however, there were too many variables and lack of statistical power in our study to determine any effects on cancer recurrence of our protocol, which also included the preoperative paravertebral nerve block. Therefore, the aim of our study was to investigate factors affecting chronic pain development in post-mastectomy patients, including the preoperative factors, anesthetic management, surgical management, and postoperative follow-up. In comparison, Carluma in 2004 studied pre-incisional single injection thoracic paravertebral nerve block for postoperative analgesia in women undergoing breast cancer surgery, which also involved axillary dissection, and they used a randomized and placebo-controlled protocol. In their study, the analgesic effect of the paravertebral nerve block was detectable for the entire 24 hours post-surgery. They did then report in a second follow-up study up to 1 year that at 12 months after surgery, in addition to the prevalence of pain symptoms and the intensity of motion-related pain, the intensity of pain at rest was lower in the group that had the paravertebral nerve block pre-op compared to the group that had a saline paravertebral block. That is the control group. In our study, the use of preoperative paravertebral nerve block was associated with a much lower initial pain scores in the post-anesthesia care unit that was statistically significant, and 80.5% of our patients reported only mild postoperative pain. The other 19.5% reported more severe pain, but even that was only 2.77 plus or minus 1.97 on the visual analog pain score. So the anesthetic management that we used in our protocol, which also included the general anesthetic, ketamine, magnesium, fentanyl as the intraoperative opioid, influenced not only the acute postoperative pain, but also seemed to decrease the incidence of chronic pain in patients having this mastectomy surgery for breast cancer at 1 year follow-up. And the amount of pain that was noted in 31% of our patients preoperatively, only 13% had chronic pain at 1 year. But a use of opioids for chronic pain preoperatively, as well as alcohol consumption in the pre-op history, should alert surgeons and anesthesiologists to patients at greater risk of developing chronic pain post-mastectomy surgery. This was the major finding of our study. So having breast cancer is a physical and psychological stress. And if you add to that the trauma of mastectomy surgery, it shows that pain control for women who undergo mastectomy surgery is the responsibility of all of us and must involve a multimodal approach to assure the best possible long-term outcome. What we showed was that a multimodal protocol that included preoperative medications, a good preoperative history, a paravertebral nerve block performed preoperatively, as well as a multimodal intraoperative general anesthetic, including things like ketamine and magnesium, provided protection for these patients in the majority of cases from developing chronic pain at 1 year post-op. So with that, I will thank you very much and take any questions.